right, well, so welcome to the October meeting for the Rural HPV Vaccination Learning Community. On behalf of the American Cancer Society and the National HPV Vaccination Roundtable, I want to thank you all for taking time out of your busy schedules to join us today, whether that's live or via recording in the future. Today will be our third session, actually, that we are able to offer live and enduring CME and CNE credits. And today's meeting is really going to be focused mostly on interventions to reducing barriers to HPV vaccination. And you're going to hear from a variety of our partners today. If you want to go to the next slide. So as always, I'm Ashley Locke, HPV Program Manager for Disparities here at the American Cancer Society. I have the honor of talking with you guys first, but I am part of a much larger team that encompasses many colleagues from both the American Cancer Society and the National HPV Vaccination Roundtable who work daily on increasing HPV vaccinations. Next slide. I know we're all kind of getting in the spirit of Halloween, and with it being mid-October, I thought we could all just go back to doing a quick icebreaker. So I'm asking everyone if they could please share their name, organization, and favorite Halloween candy in the chat. I will definitely call out a few of those as I see them come in. In the meantime, if we want to go to the next slide. So just going to share a roadmap for today's call. Quickly, I'm just going to go, or in just a few minutes, I'm going to quickly review some slides that Dr. Sara shared with us in August to refresh our memory on evidence-based interventions and those related to increasing access and reducing structural barriers to HPV vaccination. I will then be followed by a robust panel talking about their experience with interventions they implemented to reduce barriers, and then we'll wrap up with a few resources to share. So I do want to quickly share a few reminders. So all of our rural HPV vaccination learning community sessions are recorded and posted to a public-facing website. This session is certified for CME and CNE credits, and we've added a link to a document in the chat detailing out all the information for a live CME and CNE credits. You can also find this information on our website, and it'll be also linked in our slides that we share after today's session. For CME and CNE purposes, one of our panelists, Dr. Marvell Ford, would like to disclose her participation in the Cancer Health Equity Advisory Board for Eli Lilly. However, none of the other planners or speakers for today's presentation have anything to disclose. And then we ask all participants to stay muted until our panel discussion, and the Zoom chat is open for questions and support. I'm seeing really great candies coming through the chat, so thank you all for participating. You want to go to the next slide. And as always, both American Cancer Society and the HPV Vaccination Roundtable take a systematic approach to our quality improvement framework. This slide in particular showcases the different steps that our partners and us as well use to not only improve HPV vaccination rates, but also cancer screenings. And today we'll continue to explore evidence-based interventions more in depth. So excited for that. If you want to go to the next slide. Just going to review quickly our learning objectives for today's session. So we'll really be focused on describing how to increase on-time vaccination rates in rural communities, talking and listing out evidence-based interventions to increase HPV vaccinations in your community, and then compare best practices and challenges in increasing HPV vaccinations in rural settings. So very excited to explore that. And in the meantime, if you just are joining the call, would love for you to share your name, organization, and your favorite Halloween candy as our icebreaker. So if you want to go to the next slide. So I'm just going to quickly review some of the information that Dr. Staras had shared with us in August. So interventions, are best done when in combination. So there are 3 buckets that we use to define the different evidence-based intervention types, including patient-directed interventions, provider-directed interventions, interventions to increase community access. And today we'll really be focused on interventions to increase community access, which encompasses patient navigation, shared decision-making, reducing structural barriers, and reducing out-of-pocket costs. We want to go to the next slide. So this right here just once again showcases all of those interventions. And like I said, we'll really be focused on that one bucket, increasing access to the different types of interventions. And then if you want to go to the next slide. So as a public health decision maker, practitioner, community leader, or someone that cares about the health of your community, you can use the Community Guide, which is a compilation of all Community Preventive Service Task Force, or CPSTF for short, to help focus resources on interventions that are proven to work. So the Community Guide recommendations are based on credible, rigorous, systematic reviews that consider all relevant, high-quality evidence. The Community Guide has accredited a greater impact to multiple component strategies implemented within the same clinical settings to increase patient demand, access, and to improve provider delivery. The Community Guide recommends the following interventions to increase immunizations, which include enhancing access, patient incentive rewards, patient and client reminder and recall, combined community and provider interventions, required vaccination for school, immunization information systems, so the EMR or state IAS, provider assessment and feedback, which would be looking at maybe doing a provider report card, provider reminders, and standing orders. If you want to go to the next slide. So what are some of the examples of interventions to increase community access? Next slide. So when we talk about reducing structural barriers to immunizations, this means reducing non-economic burdens or obstacles that make it difficult for people to access vaccination services. So interventions designed to reduce these barriers may facilitate access to vaccination by reducing time or distance between service delivery settings and target populations, modifying hours of service to meet patient needs, offering services in alternative or non-clinical settings, or eliminating or simplifying administrative procedures and other obstacles. This slide isn't totally encompassing of all interventions, but it has ways and proven ways that some of our partners have tackled this particular topic or barrier. And in just a few minutes, you'll hear from a variety of rural healthcare partners who have implemented interventions and programs to meet the need in their community. So with that, I'm going to now pass it to my colleague, Christina Turpin, to introduce our panel.
Let me see. Can you guys hear me? Perfect. I'm Tina Turpin. I'm a director for the ACS National HPV Vaccination Roundtable, and I have the honor of moderating today's panel on reducing barriers to HPV vaccination. Next slide. So I'm going to quickly introduce this fabulous panel to all of you, and then we'll dive into asking different questions. If you have any questions, feel free to put them into the chat. But I would like to introduce Lauren Brown, Senior Director of Clinical Operations and Support from Riverstone Health, Bridget Eckley, Physician Assistant for Obstetrics and Gynecology at Billings Clinic, Dr. Marvella Ford, Associate Director, and Melanie Slane, Program Manager at the Office of Community Outreach and Engagement at the MUSC Hollings Cancer Center, and Chelsea Hafner, Lead Clinician for School-Based Health at the Wright Center for Community Health. So thank you so much. And I know there's some disclosures, and Ashley already went through those in the intro. So I think if we are all on here, I think we're waiting for one more to be spotlit. We'll dive in. Great. You guys all look great. I see you. I hopefully hear you. Let's start with a question just to kind of level set and get a little more information about all of you for everyone. So tell us a little bit more on the community you serve and the interventions you implemented to reduce barriers to HPV vaccination. And I am going to start with Dr. Ford and Melanie.
Hi, good afternoon, everyone. Thank you so much. It's a privilege and an honor and a pleasure to be here with everyone today. In South Carolina, the catchment area for the MUSC Hollings Cancer Center is the entire state. So that's 46 counties. And South Carolina is a very poor state. Our median household income is about $10,000 less than in the US. We also have a 14% of our state population that lives in rural areas. And in 2016, we had the lowest HPV vaccination rates in the United States. We also have one of the highest rates of veteran population growth, and we have a unique population group called the Sea Island or Gullah population, which is a rural and medically underserved group of Black people who live here, who are direct descendants of Africans who have the least genetic admixture with Europeans of any other group of Black people in the United States. So those unique population characteristics have led to the development of our program, which Ms. Land is going to describe.
Thank you. And I'd like to say as well, thank you so much for having us. And it is really an amazing opportunity to be able to share information about our program. So given the rural characteristics of South Carolina, population characteristics of South Carolina, and the previously low HPV vaccination rates in our state, the Hollings Cancer Center committed to building and implementing this HPV vaccination program. The program was started in October of 2021. So actually this month, we are 3 years old. So the program includes Dr. Ford, who is our director, myself, program manager. We have a driver who's also our community health educator, Miss Joan McLaurin, our medical director, Dr. Maritier Nazario, and our nurse, who is a bilingual nurse as well, native Spanish speaker, and she is our vaccine administrator. We receive our vaccines through CDC's Vaccines for Children program. Most people know it as VFC. And this program is administered through our Department of Public Health. Children who are eligible for VFC are those who are uninsured, underinsured, American Indian, Native American, or Alaska Natives, and up through age 18. We work with school nurses primarily. We do other events, but primarily we work through school districts with referrals to school nurses. We were referred to our school district nurses, our partner, Beth Poore, with the Department of Public Health, and also who manages the South Carolina Immunization Coalition. We have her to thank for many of our referrals. To date, we have served 29 of the 46 counties in South Carolina. And total, as of today, we have a total of 2,165 young people that we vaccinated. And I'm sorry, that's correct. That's incorrect. 2,165 vaccines administered. Hopefully we will get to that over 2,000 soon. But the number of young people we vaccinated is 1,350. And among the vaccines, we do HPV because that is the focus of our unit, but we also do Tdap, meningitis, MMR, polio, chickenpox, Hep A, hepatitis A, and hepatitis B.
And this is a mobile unit. So I have to say, when we were charged by our cancer center with coming up with this, we did not realize how few mobile HPV vaccination units there are in the US.
Yeah, definitely a great solution. And 1,350 vaccinated people is nothing to be shy about. So I think that's some great work happening. Bridget, do you want to tell us a little bit more about your community you serve and what you've implemented to reduce barriers?
Yeah, absolutely. Thank you guys for sharing, and it's nice to be here. Thank you for having me. I hail from Billings, Montana, and I'm with Billings Clinic, which is the largest independent hospital within the state. We're a very large state that has more cows than humans per capita. But so even though I'm in Billings, which is the largest city at over 100,000, most of our communities are going to be less than 10,000. So we have a very varied topography and a lot of rural settings within this state. So within my hospital-based system, we had to cover rural sites in a creative way. I'd love a vaccine mobile. So we were trying to reach direct patient, and then within the healthcare system, IT, EMR, EHR wise, as well as staff and clinician education. So in our side at Billings Clinic, we have over 17 regional partners and more than 15 critical care hospitals. So it was too big to focus on that. So we just took 7 sites from within Billings in eastern Montana and northern Wyoming to focus on within pediatrics, women's health, internal medicine, and family practice was who we kept track of for Gardasil. And we were really focusing on 9 to 13-year-olds to get them vaccinated to completion, preferably before 13, but before 15. And one of the ways we thought we could be creative, because people usually have to travel a long ways to come to Billings, to the main site to get care, was to provide gas cards. So like a transportation voucher, but we did them specifically with Exxon so people could have gas cards to come back and get their second vaccine. And this worked really well in pediatrics. The staff liked that really well. This is now my 3rd year for the quality improvement project for HPV. So we did that the first year, and the second year we changed it to gift cards for kids who completed it before the age of 13. And they really liked that. I think parents appreciated the gas vouchers, and then the participants and patients appreciated the gift cards to Amazon, Target, places like that. And they would get that upon completion of that second shot before the appropriate age. And then within our large healthcare system, we made to improve staff education from MA to physician, was to make some mandatory requirements. So for like nursing, who have to have certain CEs within the health system, we made HPV education and awareness a part of that. So we had some mandatory training and then some optional lunch and learns. And we did that in a bunch of different ways, depending on what department people were in. And then we tried to update the way Imatrax is who we use for our public health tracking vaccines. And there was definitely some bugs in that system. So we couldn't always tell who needed the vaccine, who didn't have the vaccine. And so we updated some things in the system so we could better track people to help them get vaccinated, or if they hadn't, get those people in within our electronic medical records, as well as made reminders a little better. So it would trigger in the system so that it would be easier for staff to see when people needed the vaccine, and the reminder call to get them back in for their next vaccine. So that's a brief overview of some of the things we did for the project in the last couple of years.
Yeah, although you say brief, I feel like you implemented a lot of different things, which I think Ashley started by saying, more interventions coupled together have bigger results. And I think we're hearing that from you really well. Chelsea, did you want to answer that question as well?
Yeah, hi, my name's Chelsea Hafner. I'm a nurse practitioner with the Wright Center in Scranton, Pennsylvania. We currently have 11 organizations, 11 pretty much buildings that do serve our underserved and underrepresented population of Northeastern Pennsylvania. We're currently in 4 counties. So we do offer a lot of kind of, I guess you can say, incentives. We do have a mobile clinic currently already, and we do offer services to all. We see a great deal of Medicare and Medicaid. So we are very familiar with our VFC program. That is primarily what pretty much drives us and gives vaccines to kids within our area. The biggest thing I can say is it was really hard for us to find an intervention that would actually work for us. I guess you can say my biggest strive was educational intervention, and that is what I went with, and that's what I pretty much strive to perfect. So what I ended up doing last year was I created an educational intervention, and I pretty much sent it to all. It is a mandatory pretty much a mandatory PowerPoint, and they had to do a post quiz, which they do still, I think, curse at me about, because our success rate was 70%. So I did make it tricky in the end. But for the most part, it was well utilized. We pretty much gave it to about 259, and of those 259 staff members, 249 did complete it. Of those staff members, it was physicians, residents, nurse practitioners, PAs, as well as our clinical administration staff. So that was our front desk and our MAs. Pretty much how I looked at it was who was the most vital role to offer this vaccine, and even our front desk. Obviously, they are the ones that schedule our appointments. They are the ones that bring those patients in, and when they're talking about vaccines, I want them to be well educated. So that was a big deal for me. And I think it was for the Wright Center as well too, because usually we just give education to our clinical staff, but they are our clinical staff. They schedule our patients. And if they don't know about HPV, then why am I gonna try to not strive for that? So we really try to make it a big deal. So I made it pretty short and sweet, but it was a mandatory thing that now is implemented every year because we do get new staff continuously as our residents because they do come in usually every year during the summer. So it's been pretty much a crucial thing for me to make sure that I do implement it to all and make it mandatory with that post quiz. And with the 70% success rate, I was a little irked. So of course I did make some changes, but for the most part, our PowerPoint has stayed the same. It's pretty much showed our collaboration with the American Cancer Society. It's gone over a bunch of stuff, but it's pretty much as easy as I can make it for all. So I did inform, we focus solely on provider and staff education, but within that education component, we did focus on other things. That provider and staff education pretty much focused on that starting at 9 was the most crucial thing for us, I noticed, because of the population that we serve. So I really focused on, yes, it's of course important to start at 11, but 9 is crucial so we can get that series completion. So we talked about that a lot in the PowerPoint, and then we went over like basic knowledge about HPV, because why are we giving a vaccine if we don't know the basics about it? And then I pretty much fed into how do we educate. So I did provide a PowerPoint slide on education to those parents and their guardians, as well as the patients too. And then we focused on the biggest goal for us was also making sure that we are aware about the catch up, because we do deal with a lot of patients who do not come back for their appointments. They tend to come back 4 years later to finish that HPV series. So I tried to make it imperative that we educate all staff that please come back within 6 months for that second one, or if we're over 15, this is when we come back for it. We did address provider and staff concerns because we are a pro-vaccine organization, but sadly there are some within our organization that do not and were not pushing for HPV, and this has been a very big deal for me. I did focus my whole doctorate on HPV and HPV education and initiatives. So then I focused pretty much back on the concerns that if they were to be asked anything, how can that provider or staff address them? So we did discuss, of course, coverage, insurance, and cost concerns, as well as the safety and efficacy of these vaccines in this vaccine series. So that was really important to me. So I hope it worked. And I mean, they probably are cursing my name and I have to give it to them every year, but I do not care. So it is something that I do implement and this will be our second year, pretty much putting it out to the organization. And hopefully I make the quiz a little bit easier, but I'm sure they're just going to curse my name and I do not care as long as we get HPV out there.
Right? All in the name of preventing cancer, saving lives. So it's worth it. And I like that you brought in educating front office staff, because that is the person you see first. It's who you're saying, what's going on in this appointment? What should I expect? And if we're not speaking in one voice across the clinic, I think it can really have an impact in the feelings towards HPV vaccination going forward into seeing the physician. So I love that. And Lauren, same question.
Hi, everyone. Thank you so much for having me. I'm excited to be here. So I am a neighbor with Bridget, who just spoke recently. She's actually just up the street from us. We are the federally qualified health center for the Billings area in Yellowstone County. And as Bridget mentioned, we are kind of the medical hub for this particular area. So not only do we serve both our county and surrounding counties, but we also do serve patients both from North and South Dakota, as well as Wyoming and some other areas. So we have a pretty broad cross-section of area that we cover. With our particular federally qualified health center, we do have kind of a main urban clinic here within the city of Billings, but we also have rural clinics that are anywhere between 25 to 40 minutes outside of the city, as well as 2 dedicated healthcare for the homeless sites and 3 school-based health centers. So we have kind of an interesting cross-section, and being a federally qualified health center, serving the underserved and those that may, have some financial barriers, that type of thing. I'm a high Medicaid population, as you mentioned as well, Chelsea. So kind of taking those pieces into account when we were making our decisions. And really one of the biggest areas that we wanted to focus on was improving access just across the board with kind of the large landscape that we're covering, as well as reducing barriers. And whether those were, like I mentioned, financial, transportation, whatever it might be, and just kind of trying to make it as easy as possible. So one of the first things that we did again was education. I mean, that was pretty critical, just making sure all our staff was on the same page, and especially the Y9 kind of movement that the American Cancer Society had put in. It was actually quite amazing how many of our staff were unaware that that change had been made, and that the recommendation was for 9. And so that was kind of our first thing. And Chelsea, similar to what you and your staff are doing, we do offer that training across the board for everybody in the health center. We're kind of unique here in our organization. We do have the clinic, but we also umbrella over our public health department. And so we were able to utilize our public health nurses to come in and do that training, as they're a really great resource and kind of a subject matter expert on it. And so they came in and have done some really amazing training for our staff and some great education. And they're a super fun group, so it always makes it really wonderful when they do that. So that was kind of the first phase of what we did. And then the next piece was really making every single appointment a vaccine appointment. When you're talking about people having difficulty getting here, having financial barriers, if we get them in the door, we wanted to make sure we could offer any vaccine, not just required, any optional, any available. We had our chart prep getting done to include any vaccine that was age appropriate for a patient and recommending them. And if a patient declined at a visit, we just offered it again the next time. And that was one thing with the HPV vaccine that we did see. We'd have patients decline at 3 visits, and all of a sudden on visit 4, they would decide to get it. And so I do think that was really effective, possibly a little annoying for patients at times. But I think that kind of squeaky wheel gets the grease. And so it has been very effective, and we are continuing to do that. And we have implemented a system where we can do walk-in vaccine appointments as well, both within our nurse clinics. And then our public health team does have a dedicated immunization clinic, and they are able to offer those walk-in vaccine appointments as well, which has been really helpful. And the next initiative that we put in that has been really effective for us is around our sports physicals. And so especially with our rural clinics, we do dedicated sports physical days and our school-based health centers. And so we kind of have a bit of a captive audience. We have those children coming in within that appropriate age range, and ensuring that we have the vaccines there to offer for them those days. Something else that's kind of interesting here, that I hadn't seen in other areas where I had worked before, was kids coming in with their consent form and a check signed and no parent. And so we made sure that we did include the opportunity to have the HPV vaccine along with all available recommended vaccines on that consent form, and any cost that may or may not be associated with it included, so that if a parent did decide to consent, we could offer it that day. Obviously, having the parent here was ideal, but it was pretty amazing when our providers were having conversations with the children and their parents. A lot of times it was actually the kid who made the decision to want the vaccine based on that conversation with their provider. So that was kind of something that was really interesting. But it's been really effective. And again, when they're here and we have them in the building, if we can offer that vaccine, that's kind of been the most effective for us. We're also something new that we are just starting. We might be slightly behind the times on this, but welcome to Montana, is online scheduling. And so we are trialing that in our public health immunes clinic, and hopefully it will go well, and we'll be able to implement that across the board here relatively soon, again, to just reduce those barriers and kind of be able to have that done out ahead of time. So those are kind of the main things that we did here at our sites.
Yeah, great. And I love that. Make every appointment a vaccine appointment. I feel like that is a good reminder kind of like, what else could we be looking at to keep this person healthy during an appointment? And so I love that a lot. So our next question is, all of you have implemented things. You're doing fabulous. That's why you're on this panel. But how did you get to that point? So how did you identify the best solution to overcoming patient barriers? And then were there specific quality improvement processes, such as a process map, gap analysis, PDSA cycle, something like that, that you use to kind of help you along to get to where you're at now? And I'm going to go back to Marvella and Melanie.
Great, thank you so much. So, we started by saying that in 2016, South Carolina had the lowest HPV vaccination rates in the US, but we're really pleased to report that as of right now, the teen vaccination rates for HPV in South Carolina surpass the rates of the US. And it's because of the work of our team with all of our partners across the state. So when we first started developing this program, we met with our state health department, and one of the first questions that they asked us was whether we would be willing to administer other childhood immunizations in addition to the HPV vaccine. And we said, absolutely. And that was really a game changer because when we talk about partnership, there has to be a win-win in a partnership, right? It can't just be, we need you to help us. What can you do for us? So we were able to really fill a gap with the school systems across the state that Ms. Lynn, Melanie was talking about. Especially coming out of the pandemic when so many children were behind in their immunizations. And so we were able to, roll up to the schools in our mobile unit with our, HPV vaccinations and all the others and get the kids caught up in their required, state required immunizations to remain in school. Because a lot of kids were about to get letters asking them not to return to school because they were so far behind. So that really helped to make a really solid relationship between our program and the school nurses. And again, Ms. Beth Poor is directs our state childhood immunization program, and she linked us with all of the school nurses in all the school districts across the state. So that was a game changer. And then I think that Ms. Land can talk about our town hall meetings and everything that we did to kind of lay the groundwork for working with these school districts and developing the multiple partnerships across the state that we have with school districts and with community organizations.
And so prior to us holding our first immunization clinic, and our very first clinic, school-based clinic was in Cherokee County. And their school nurse administrator suggested a town hall approach because there was still, and when we started in 2021, still in the throes of the COVID pandemic. And so vaccine hesitancy for COVID seems like it kind of slid over to the HPV. And so their suggestion was that we host a town hall, and which we did. And we included, the panel consisted of our medical director, a gynecological oncologist here from MUSC, who explained what the HPV virus is, how it works, how an infection is treated. We also had, which really powerful part of that town hall event was one of the high school, a science teacher from the Cherokee County School District, and her son. The school teacher was very open about her personal journey. She had a high-risk HPV. Thankfully, it did not turn into an HPV cancer, but she had to be treated for that high-risk HPV. And sharing that with her son, he decided at 14 years old that he would be vaccinated. And he shared that I hated that my mom went through this and I did not want to see my future wife, or I don't want to see any woman that I care about go through that. And so that, said a lot, and it spoke volumes towards educating people about the HPV vaccine. And so we have shared that copy of that town hall event with several of the other school districts that we interacted with. They either use that format, it's already, all of the questions, everything is set. So they share that at either a parent-teacher conference meetings, different formats like that. And then we've also done an in-person one in the community in Orangeburg, and then we did another virtual session in Jasper County. So we found that that's a very helpful tool because it takes away a lot of the mystery about and the misconceptions that people have about HPV. So that was very successful. And
we also educate the parents. I love what you said about using the PowerPoint, the educational tool. So we use the National Cancer Institute's HPV educational module. And so our health educator meets with each parent who's considering vaccination of their child, and she educates them one-on-one. She spends, I think 20 minutes with them going through the module. And so we have been collecting pre-educational session and post-educational session data on changes in parental knowledge, attitudes, and beliefs and behaviors around the HPV vaccination and willingness to have their kids vaccinated.
I love that. I like how we're all working with unique populations, unique communities, and the very personalized approach you have with a town hall. I think we all make assumptions about where we're working, whether we live there or not. And so kind of giving that opportunity of like, what questions do you have? And personalizing it with stories from the community. I love that approach. Chelsea, I'm going to hand that over to you next. Just how did you identify the best solution for overcoming? And then are there any specific quality improvement processes or tools that you used?
Yeah. So I'm very fortunate with the Right Center that we already had a mobile unit in place. And then we also, of course, did online scheduling. There was a lot of things that we're very fortunate for, but of course, we are always trying to consistently make it better. How could we make it better and how could we do better and be better? So a lot of these things were like tough since we had already implemented them. So like it was like one of those things like how did we come up with an idea to improve our vaccine uptake on HPV vaccine? And so the educational component came into play because it seemed like our numbers were still on the low side. So I had done my doctorate several years ago, and I focused solely on my school-based health clinic where I'm the main clinician. And the biggest thing that we realized is we weren't educating properly when they came in for the vaccine. We were only striving to do the Tdap and the meningococcal because that was the requirement at 11. So then I took a turn on it and I said, what if we no longer said, hey, you're eligible for these ones, but said you're eligible also for HPV? So that changed and that added and pretty much strived me to make that a key component in our educational intervention. And I did that with the help of a PDSA. Our organization strives with PDSAs where we are required to actually do 6 staff. Every single staff member has to do 6 a year and they have to lead at least 3 of them. So as a main clinician in a school-based health clinic, sometimes you think that they're not that easy to get. They are when it comes to vaccines, especially when I'm striving to make our numbers go up and make sure that the rest of the organization, their numbers are also up as well too. So like the biggest things that we do push for is just implementing those PDSAs, seeing where we are flawed, I guess you can say, what are our barriers and how can we break through those barriers and continuously make ourselves better. Each individual clinic as well as the whole organization. So the biggest thing is just making sure that I continuously make changes and edits to things. So the educational intervention that I did give out last year is definitely going to be edited. But the biggest things and the biggest components are, of course, starting in vaccination at 9, making sure that we are properly discussing vaccines because in most of my research, when it comes to vaccines, they trust their provider or their staff that is in that clinic the most. So of course, if a parent or guardian and that patient themselves has faith in us and they trust us, then they are going to fulfill any vaccine requirement that we pretty much put out on the table. So if we don't go into a situation with any, like if they can smell our fear, they're not going to do something that of course we would love them to do. So the biggest thing is just making sure that I kind of looked at every component. I took what I had done in my doctorate and I just kind of continuously built on that. So these basic little PDSAs that I had started and kind of strived for with meningococcal and Tdap, I just continuously keep applying it with HPV because that is my sole passion and my favorite vaccine. So I'm a little nerd, and they do call me the HPV vaccine queen at our clinic and our organization. I literally, if I can strive for anything, that is the number one thing because, of course, it's cancer prevention. Why wouldn't we want to prevent cancer from happening? And why not start early when we should and could and can? So just continuously utilizing our PDSA format and then pretty much including all of our staff members. So our PDSA component, we can of course include all staff, whether it be our residents, our doctors, our clinical administration staff, and those medical assistants. Everyone can be included. They find it very tedious because they get notifications every single edit you make on that PDSA. Every little email, every little change, you can put a period on something, as long as you save it, everyone's getting an email. But pretty much when something is updated or implemented within the Right Center, everyone is made aware and notified of it. So any changes that I make within anything related to a vaccine, including the HPV vaccine, somebody will get notified. So of course I definitely have crawled up somebody's butt and they're definitely miserable with me, just like the PowerPoint, but we continuously strive to make sure that we're implementing things that are appropriate for our organization. And the biggest thing is vaccine uptake for us. We strive to get those numbers up continuously. The biggest challenge, I guess you can say, was actually implementing my educational intervention because we have so many different layers within our organization. So I'm just one little tiny person, and there's so many more. So I had to get multiple people's approval to actually make this a mandatory requirement. And we utilize collaboration. So it is a place where we, of course, can put out our OSHA trainings and things that are required every year. So these are actually making it mandatory is a slap in the face to everybody, because if they do not do it, they do not get their bonus. So they're not bonus eligible if they do not do this HPV intervention PowerPoint and actually pass the quiz. So yeah, I'm definitely hate list number one, but I'll take it. So
No, and you got some HPV crown queen in the chat, so we are definitely thankful for
thank
you holding that title. Bridget, same question.
Yeah, I'm fascinated at Chelsea's response that we don't have that trust in our healthcare system. I would say patients most influence are TikTok, not their healthcare providers. So I'm blown away that they would trust you just saying the vaccine's good for them. I do not have that here in Montana in general.
Oh, I think you got muted somehow, Bridget.
Probably because I did. I
No.
did. Self-mutilating over here. So the tools I use to assess, to figure out how to best reach it, because I don't think you can fix a problem if you can't see there is a problem. We use workflow mapping and gap analysis, but I really, really like the fishbone diagram. I'm a clinician, very tangible. There's a lot of lofty things, but I need the pragmatic side of it. I'm a big, I respect social advocates like Reverend Desmond Tutu. One of my favorite quotes from him is, there comes a point when we need to stop pulling bodies out of the water and find out why they're falling in. And I felt like the fishbone diagram helped me check the different streams where people seem to be falling in. It helped me see like the data side of things, which we wanted to decrease HPV-related cancer deaths and increase the number of vaccinations. We could break down the IT system, getting Imatrax, getting people into the public health system. We could see the methods of how to do a lack of clinician or manpower, staff turnover. Mother Nature was a good group that we called, like, how can people get to us? How do we get increased access? How do we mitigate social media as the influencer? How do we use that to our advantage? How do we educate providers and clinicians to talk to people, as well as educate patients and their parents on that it's a cancer prevention, not to talk about sex. So, and then that would help us break down the staff training competence as well. So I felt like the fishbone diagram is what helped us really see which problems and we get to the root of those so we could trickle down into a positive effect.
Love that. Yeah, I think it's hard to implement change, like you said, if you don't know the problem. So these tools that you guys are talking about are definitely helpful for all of those on the call, kind of at that beginning stage of where to begin. So I think it's really helpful. And then Lauren, same question.
You bet. So we're really lucky here at our organization. Quality is really pivotal to everything we do, and we take it very seriously. And so all of our staff, when they come on board, actually get Lean Six Sigma training. They get their white belts right when they come in the door, and then have the opportunity to advance and get, additional training with that. And so, a lot of the, quality tools are pretty innate to staff here. And so when we started this project with the ACS, we did just went to the basics and did a, current state process map to see where we were actually at, and identified some major gaps there that we didn't realize were happening. And then kind of built out what we wanted the future state to look like, right? Where are we at? How are we going to get there? And then same thing with what Bridget just mentioned. We definitely broke out the old fishbone. I am a big proponent for that one. I think it's really helpful to kind of identify those gaps and really get down to kind of that root cause of what the issues really are. And again, we found some kind of enlightening things that we, maybe didn't realize at first glance were kind of going on in areas that we needed to focus on. And once we kind of had that lined out, we started just sort of, spitballing any initiatives we thought that potentially could help fix the problem and sort of put them all into a 2x2 matrix, which is something I also really like to really identify which ones, number one, we have the resources for, what's going to give us the best outcome with the input that we have available to us. And so that's how we kind of identified what initiatives we were going to start looking at. And then we just did a lot of rounds of continuous PDSA cycles. And we were initially, when we started the project, we were kind of doing them almost monthly. And each individual site that was participating, so all of our rural sites were involved in our school-based health centers, they were doing individual PDSAs. And then we were also kind of looking at it from the overarching kind of organizational perspective as well, just because we were trying to get continuity with what we were doing, but also with the understanding that each individual site had their own kind of population and barriers and things that they had to look at and identify as well. And I mean, I think it was relatively successful and kind of made for a fairly streamlined, direct project.
Great. A lot of love for PDSA cycles and fish bones. And if you're on the call and you have no idea what we're talking about, visit the past sessions. That will share the resources at the end, so it can help you get started on these. And we have a few questions in chat I'm going to give to you guys now. And I'm not going to call anyone, but if you have an answer, just feel free to chime in. So the first one we have is, with the mobile units in various states, were you able to vaccinate privately insured children / athletes? And if not, what was the recommendation for those children if they were not up to date with HPV?
So we would love to go there because one of the rate limiting factors of our program is that, as you heard, we receive our vaccines from the CDC's Vaccines for Children program. And so only the children who meet those criteria are able to be vaccinated. And so, as excited as we were when the upper age limit was raised to 45, 19 to 45, we have such a missed opportunity because we cannot vaccinate privately insured children using the Vaccines for Children vaccines, and we cannot vaccinate people who were 19 and over. And with all of the colleges and universities in the state, when we first started, we had probably, I think, 10 or 12 meetings with colleges and universities, because my first thought was, let's go for the low-hanging fruit, right? College students. We can just roll up to the student health center, of course, making arrangements and doing the workflow, but roll up and think about how many college students we could vaccinate with a mobile unit. I mean, but when we met with the college administrators, they did not know which of their students were insured and which were uninsured. And our program would only allow us to vaccinate those who were still 18, who were uninsured or underinsured. And so we had to actually stop those meetings after a while, because we just couldn't, in the spirit of equity, we couldn't pull the unit up and then turn students away because they had private insurance. Now, for the middle, elementary, and high schools that we work with, the school nurses are able to identify in advance which children, of the insurance status of the children. So, as with many of you, most of the children that we vaccinate are Medicaid or Medicaid eligible or equivalent. And about 30% or more of the kids that we vaccinate are Hispanic or Latino. But we know there are more that we could reach. So missed opportunity is being able to vaccinate privately insured kids and adults who are 19 years and older. We're constantly looking for sources of funding. Any financial partner who could work with us, who could potentially help to provide funding so that we could purchase the vaccines to provide the vaccinations to people in those groups.
Great. Anyone else want to chime in on that question before we move to the next one? No, and kind of, Marvell, you set this up, but how are you guys getting funding for incentives you're offering? And I know, Bridget, you put something into chat, but a few of you talked about incentives. How is that funding coming?
Yes, so our mobile unit is funded through Healthy Me, Healthy South Carolina, which is a state-funded partnership between the Medical University of South Carolina, and Clemson University. That's about 40% of our funding, and about 60% of our funding is from the MUSC Hollings Cancer Center. So between those two sources of funding, we offer gift cards to the parents who complete the surveys. So when we do the parental surveys, we then give mail gift cards to the parents who complete the surveys.
Backpacks donated.
And we also have backpacks. We work with
The Immunization
organizations
Coalition.
and the Immunization Coalition. I see that Ms. Beth Moore is here, and her group has provided backpacks for the students. So we've been able to help to try to meet some of the other needs of the students. We had our very first, we just formed a new partnership with the Charleston Hispanic Association. So we partnered with them in their back to school bash. And so this was an amazing day. We administered 32 vaccines in 3 hours. But meanwhile, the kids we vaccinated received backpacks, all kinds of school supplies, lunch. It was just a great day because, of course, the communities have needs beyond the vaccinations. But that's pretty much how we're funded and how we provide incentives. Thank you.
Yeah. Anyone else have anything on funding, incentives, etc.? Now, I love that you brought up that community groups and partnerships. I think that's so huge in the work we do in rural communities of getting to know the community and the partners that work within that community. So I love that you brought that up. And we have about 5 more minutes left in our conversation. And I love a dream space question. So we're gonna go there because that's where I live in the dream space. So if there in your dream world, anything's possible. Are there any new or innovative ideas to reducing access barriers that we haven't talked about that you would love to implement if you were able to? Marvell, I feel like you got something. We
Oh,
heard a
yes,
smile.
sorry. So dream, it goes along with what we just talked about. If we could have funding to allow us to vaccinate people 19 to 45 years or privately insured kids, our numbers would skyrocket and we could really help to meet a need. There are kids at the schools that we go to who have not received the HPV vaccine or some of the other childhood immunizations who are privately insured. We would love to offer the vaccines to them as well. So if anyone knows of a source of funding, we're always looking for partners. We are not ashamed to ask for money because it's for the greater good of the people in our state. So if you know of any organizations, and again, we partner with different communities. So there have been times when some of our community partners had funding, they said, we'll pay for the vaccine. So we have done that before, but those are few and far between, and they're not really a consistent
Yeah, just episodic.
pattern. They're episodic, not consistent. We really want to try to have a source of funding that, because we're statewide, that would allow us to offer these vaccines to people who are maybe outside of the vaccines for children eligibility window statewide on a consistent basis.
And while we're really dreaming, it would be lovely to have funds to support a second team, but Spanish speaking. So while we're dreaming.
Yeah, no, that's what it's about. And then Chelsea, HPV vaccine queen, what would you dream?
Well, we talked about it, but those gift cards, man, they come in handy. You get anybody in. If it's free, it's for me. That's my thing. So like I don't blame anybody. I'd come in for a gift card too. You can stab me wherever, I would say. But like the funding for like those gift cards to get, that's an absolute dream. Truthfully, I think anybody would want something like that. And then truthfully, to be able to go into the schools to educate more, because as of right now, it's just that's where the kids are. So they're the ones that are making most of the decisions, and they're scared and petrified of shots. So like, why not have the opportunity to go in and educate them, and then also have them take that education to the parents, but then also involve those parents in on that education component too. So just getting out to the masses and talking and educating as much as we possibly can.
Yeah, I feel like all of our dream space is more time, probably. If we had more time to do all this. But Bridget?
Well, you guys are kind of some of my dream things. I'd love a mobile thing. I'd love online scheduling. I'd love shots given at sports physical. I'd love a Chelsea replica here. Those would all be wonderful dreams. Again, like getting into schools and educating parents and students would be amazing, but in our community, especially public health, I can't even talk about period equity without them thinking it's sex education. So that's awesome. So one of my dreams would be to have like smart phrases within, which I think they kind of exist, but for providers to have an easy tool within the EMR to use for HPV, and that would go all the way down to MA front desk staff, everyone, so they feel empowered to be able to answer immediate questions from patients. And then I thought one of the simpler things we can do, and I don't know if it's been done, is to send out like a birthday campaign. So when kids turn 9 years old in our system, why can't we send them a cute little handout on what this HPV cancer that can be prevented starting at the age of 9, and have a fun little birthday
Oh my
campaign.
gosh, I love that so much. That's not even funny. That's adorable. I approve.
Good.
I approve.
Thanks.
Awesome. These are great ideas, and they don't seem terribly unfeasible. I feel like we can get there with most of these. Lauren, did you have anything to add?
Yeah, so one of our dreams is coming true. We are actually getting a mobile unit. And so that is something I'm really excited about to kind of take our show on the road a little more. Our public health team does do it. And actually somebody had asked a question about standing orders. And we modeled that after our public health communicable disease nurses and have standing orders for our nurses in the clinic. And we do have kind of a standing order type situation for our MAs. They do still need supervision, not like our RNs or LPNs would need. But that has kind of allowed us to expand it. And so being able to kind of put that into the mobile unit and get out to the community, especially for our unhoused population, and some of our Native American populations kind of on the reservations that do have some kind of medical barriers, in sort of a desert situation. And so I'm really looking forward to being able to kind of do that. So that's something that is really exciting, and it might actually happen. So.
Great. I think we're at time, and like Bridget said, a lot of you are the people on the call's dream space. You're doing the work that they're dreaming of doing. So I just want to do a huge thank you to all of you for being on today for the panel. And then there's some stuff in the chat too. So if you have anything to contribute, panel, feel free to chime in there. And then Hannah, can you go ahead and share the slides and I'll wrap us up. But again, huge thank you to you guys. This was wonderful conversation. And I can see us continuing this conversation for the future. And these last few minutes, I have a few wrap up things for you guys. Next slide. So as always, just want to bring back attention to our external facing site for you. At the top, we have a spot that has all the past recordings, the resource roundup, past slide decks, anything that you might need. And the link is in the chat as well. So if you bookmark that, I know I've come back to this page at random times when I need things. So it's really great resource to have. Next slide. We've also organized a resource roundup. And so anything that you guys are throwing into the chat that's like, hey, my clinic has this resource, here's a link to it. We have this and that. We've been adding to this resource roundup. So this is a good spot if you're thinking about how do I get started, what has been done. There are a lot of resources here to get those wheels turning on what you might want to be doing. Next slide. And one of those resources that we have is just a great document that you can use with your teams to assess and identify the best EBIs and test out change. So this document will allow you to put all your ideas into one place and talk through your current state, examine feasibility, work to gain support for your interventions, and then test it out. So this is one of the resources that we talk about on that resource roundup. Next slide. And we are gonna have a poll here for you guys. So if you could launch that. So a few questions. In working with your communities, have you been able to identify opportunities to reduce barriers to care? What interventions have you implemented? And then has starting HPV vaccination at age 9 increased patient access in your clinic or community? So we are gonna leave that poll up for a minute, but let's go to the next slide. So just to remind you where we're at, our next session is on November 13th, and we're going to explore alternative vaccinators for HPV vaccination. And so we are coming down to the end of our 10-month journey. But like I said, if you've missed any of these, as you see the other topics, you can find all of those on that website I talked about. Next slide. And a call to action. We love a call to action for you guys. So in between these sessions, we hope that you're looking at a few things. So as a follow-up for today's discussion, we encourage you to work with your QI team to identify barriers and then pull data, whether it's quantitative, qualitative, identify interventions that might be able to solve these barriers, and then start working to implement them. So we've heard a lot about PDSA cycles today, and we've talked heavily about that in September session. So if you want to revisit that, you can use that and start practicing. And then we also encourage you to visit the website and look at the resource roundup. Next. And if you are watching the post version of this, the recording on the website, here is the information as well as the link will be in the comments of the recording for the video. And then you must answer the post-test questions to receive a 70% or better and complete the program evaluation. And those certificates will be emailed within 3 to 4 weeks. And the session is available for CME or CNE credits until October 18th of 2025. Next slide. And that is it for today's session. We'll see you again in 3 weeks for our November session. And again, thank you to the fabulous panel that we had today and to Ashley for putting this all together as always in the fabulous ACS team. Thank you, everyone. Have a good day.